So as people funnel in, I'll just give a really quick rundown of what the session is and how it's going to go. So this is our one of our tools, tech, and expertise sections. So we'll start with Jerome Kim. He's going to be telling us a little bit about vaccines, and then the next speaker is Ariel Koren, who is going to tell us about the need for translation in COVID response, this language translation. Then we have Kim Prather and Jose Jimenez, who will be speaking sort of back to back, both talking a bit about sort of aerosol science, airborne transmission of COVID. And then to end the session, we have Deepti Gurdasani, who is going to be talking a little bit about the role of children in spreading COVID. So I'm pretty excited for this session. I've met a few of you guys, and I've been following many of you guys for months now. So it's good to finally meet you guys, even virtually, and have you here. If you guys want, we could start a little bit early and get ahead of schedule. So I'm sort of scheduled for like 3 more minutes of intro, but I don't have anything else to say. So if everybody's fine with it, Jerome, the floor could be yours.
Okay, great. Let's see. Right. Good afternoon, and thank you to the organizers for allowing me to speak today about COVID-19 vaccines, the next questions. I'm Jerome Kim. I'm the Director General of the International Vaccine Institute, a small international organization that discovers, develops, and delivers safe, effective, and affordable vaccines for global health. You probably never heard of us, but whenever you hear about a cholera outbreak anywhere, that is our oral cholera vaccine, technology transferred to 2 major companies which make that vaccine for global health. These are disclosures. I'm a consultant for SK Biosciences, and IVI itself works with 4 different COVID vaccines in human clinical trials. All right, so I think many of us remember probably what it was like back in December of 2019 before we even knew about COVID-19. But in that short time, in 12 months, we went from probably now over 300 candidates to finally seeing vaccines that are safe and effective against COVID-19, at least for 2 to 3 months. This is from the World Health Organization, 291 vaccines, 68 in clinical trials, and 4 approvals. And you can see them listed down there, broken down by the type of vaccine, RNA, DNA, non-replicating viral vector, replicating, inactivated vaccines, live attenuated vaccines, protein subunits, virus-like particles, and others. But if vaccines are the answers, I think the critical issue is, what are the questions and what remaining questions are there? So these were the big questions. Can you prove a vaccine works? And I think we have done that with a number of different types of vaccines. Can you make that vaccine in significant quantity at high quality? And can you use the vaccine effectively? And can you use that vaccine with respect to access and equity for everyone in the world? So I'm going to address one of the issues first, the potential for near concurrent access. So I think many people don't realize this, but vaccines developed in the United States or in Europe often don't make their way out to countries in the developing world for some period of time. A highly effective vaccine against rotavirus, for instance, which was approved by the US FDA in 2006, approved by World Health Organization in 2009, given a recommendation for use by the World Health Organization in 2009, taken up in over 100 countries in the world, still has a problem with access. 11 years after WHO recommendation, 60% of the world's children do not receive their 3 doses of oral rotavirus vaccine. If this happens with COVID, we've seen some of the modeling. Global COVID deaths will double, and the impact on highly advanced economies, that is the high-income countries, will probably be between $4 and $5 trillion if access and equity cannot be assured. So the WHO, CEPI, the Coalition for Epidemic Preparedness Innovations, and Gavi, the Vaccine Alliance, have joined 189 countries to organize something called COVAX, which is really remarkable in a sense, because it's a first attempt to give low and middle income countries in particular near concurrent access to novel vaccine technology, in this case, the COVID-19 vaccines. It's coordinated by Gavi under something called the ACT-A Accelerator Activity, the Access to COVID Tools Accelerator. 92 countries, so these are not only the poorest countries, but also lower middle income countries, will be supported by an advanced manufacturing commitment to COVAX, so they could get their vaccines free or at low cost. COVAX intends to have 2 billion doses of WHO pre-qualified vaccine available by the end of 2021. And this corresponds to roughly 20% of expected need. So they could vaccinate the elderly in their populations and also healthcare workers. So that's the good news. But with COVID-19, we always know that there's some bad news that follows. And the bad news here is that about 9 billion doses are already pre-ordered, mainly by high-income countries. And again, I've mentioned this before, but modeling suggests that we need to be able to provide some access and equity to low and middle income countries, or global COVID deaths will double. The next question is actually a real one. Is COVAX at high risk of failure, which is what Reuters reported at the end of December, or has it met all its vaccine commitment targets, which is what WHO announced 2 days later? So this is actually the latest modeling from COVAX, and it shows you when they anticipate, or what their anticipated vaccine supply will be. So you can see AstraZeneca, Novavax, Pfizer, Johnson & Johnson, Sanofi, GSK, and you can see whether these vaccine deals have been signed, whether they've been committed to but not yet signed, and you can see that there are a number that still have designations, candidate A, B, and C, which probably correspond to Chinese vaccines or potentially Russian vaccines. But the big picture here is that if each person globally receives 2 doses, and all the vaccines except for the Johnson & Johnson vaccine are at least 2 doses, that's 16 billion doses. To reach what we hope might be somewhere near herd immunity globally, that will be 10 to 14 billion doses. So some estimates are that it'll be 2023 to 2024 before enough vaccine can be manufactured for all countries to have sufficient vaccination levels. Recent modeling supported by work by the COVAX and CEPI would suggest that maybe by the end of 2022, we'll be able to manufacture enough doses. Now, to put this all in perspective, rotavirus vaccine, again, one of my favorites, again, used globally in over 100 countries. The annual production of rotavirus vaccine from 4 manufacturers, 100 million doses. So we are talking here about massive production of vaccines. An important point to remember is that vaccines don't save lives, vaccination does. Keeping an eye on the 16 billion dose figure, we're going to have to go from what I call the EPI, Extended Programs of Immunization, which vaccinate children around the world. And it's important to recognize that 80% of children around the world actually do get the basic coverage with vaccines. But we're going to have to go from that, the children, to vaccinating their teenage brothers and sisters, their parents, and their grandparents. So we're going to need to go to a universal program of immunization. Logistics, shipping those 16 billion doses is going to be a major problem. In order to ship 8 billion doses, it would take 8,000 jumbo jets. 16 billion doses, 16,000 747s. There are going to be multiple vaccine formats. So how are you going to prioritize the use of those vaccines? So I think many states in the United States, for instance, have age-related phases, and sometimes they get very complicated. And again, one of the things that those of us who work in global health recognize is the more complicated the delivery is, the more difficult it is to implement, especially now when you're implementing 16 billion dose vaccination campaign. So remember that the vaccine is only a weapon in the fight against COVID. And we do continue to need a comprehensive strategy of prevention that will include masks, distancing, avoiding crowds, tracking, tracing, and all the things that we're doing now. plus good logistics, an army of vaccinators, and a receptive public. Will we have to use celebrities? That this is actually Elvis Presley getting his polio vaccine. I think we can do it, but we're going to have to work very hard to ensure that the program is implemented efficiently. This is the status of COVID vaccination worldwide, total number of doses administered in the beginning of January. You can see we have made some progress in terms of being able to deliver millions of doses. I think what you'll notice, though, is a big gap in the map. Look at Africa. Look at South Asia and Southeast Asia. Look at Australia. We're not necessarily doing a good job of vaccinating all the countries in the world, bringing up the question that was raised. If we do not have access and equity in the first 2 billion doses, the global COVID deaths will double, and the cost to high-income economies will be in the trillions of dollars. This is a simple list for those of you who aren't keeping track of all the different vaccines. These are the vaccines that are in phase 3 or have been approved. There are probably some names there that you don't recognize. The chart is broken into groups, stratified by neutralizing antibody titers. Neutralizing antibodies are infection-fighting proteins induced by vaccination that bind to and inactivate viruses. So that's the class of antibody, infection-fighting protein, that scientists believe are the most critical for vaccines to develop, for vaccination to induce. And they're broken into 3 groups, those with neutralizing antibody levels under 100, those between 100 and 500 in yellow, and then those with greater than 1,000 titer in green. You can see that efficacy is distributed across all groups. So maybe you don't need a lot of neutralizing antibody, or maybe neutralizing antibody isn't what we should be measuring. Yeah, we don't know that for sure. You can see the efficacies there. Sinovac hasn't formally published. It's leaked a number of different efficacies, and they varied between 50% to 91%. Gamaleya is a Russian vaccine. You can see in that big broad group of yellow a number of different vaccines, and some of them actually, such as the Pfizer vaccine, have been approved by a number of different organizations and the World Health Organization, which is actually very important. World Health Organization approval is necessary in order for a vaccine to be supplied to COVAX. Just yesterday, Moderna's vaccine was approved by WHO. So again, you can see that it in green, the second to the last one, with efficacy of 94.5%, is approved in the US, in the European Union, and now by WHO. So theoretically might be available for COVAX, except that they haven't yet announced the signed deal. One important thing to realize when I talk about the neutralizing antibody titers is these are not necessarily done by the same lab. So each company did its own neutralizing antibody levels, and that actually creates some uncertainty, and it may make it difficult actually to formally compare one vaccine's neutralizing antibody levels to another. There are some additional questions now. We have 6 vaccines showing short-term efficacy and safety, some of which that have been approved. What's next for vaccines? There are some other very big questions, mainly scientific ones. Optimization of dose, schedule, and boost, correlates of protection. That is a laboratory assay that predicts whether a vaccine is going to work ahead of doing a trial in 60,000 people. Effectiveness. We talk about efficacy all the time, and sometimes we get efficacy and effectiveness confused, but effectiveness is really real-world evidence the vaccine is actually doing what we want it to do, which is to reduce the burden of hospitalizations and deaths and disease and transmission in populations, not in individuals. Remember that when we do a phase 3 trial, what we're actually looking at is protection of an individual. The phase 3 trials now, I think worldwide, there are over 240,000 people enrolled in phase 3 trials, actually do not answer a key question around transmission, which is something that we need to understand in order to develop accurate estimates of what it will take in order to develop herd immunity. We need to know more about surveillance for mutations or new emerging coronaviruses. And then I think many of you have probably read about the mutations now that have scientists concerned. We have to have much better long-term follow-up for safety. Remember that these vaccines are safe and effective, but only at 2 to 3 months. And finally, we're going to have to figure out how to increase vaccine acceptance, and that will mean overcoming opposition to vaccination. So are there other vaccines? Yes, and you can see where in the world phase 3 trials are being done, and also the other vaccines that haven't yet announced safety or efficacy. In red are shown some of the vaccines from elsewhere in the world that actually have been approved by different regulatory agencies. Optimization of scheduled dose and boosting. And this is still a big problem. And I remember we actually had a reviewer write back, of course they've been optimized. Well, in fact, just if you scan very quickly the data from AstraZeneca, they talk about the full dose, that is getting a full dose of AstraZeneca's chimpanzee adenovirus vaccine, followed by a second full dose at least a month later. And when you read that, you should understand that the vaccine wasn't given the way a standard vaccine is given at time 0 and 4 weeks. It was given at time 0, and then at some point in the next 3 to 6 months, another dose was given. And that's not usually the way these vaccines are authorized. But the interesting thing is that they had a separate incident where a number of people received a half dose first, followed by a full dose. And that half dose appeared to be much more efficacious, with efficacy rather than 62%, which is their standard regimen, an efficacy of 90%. So again, optimization of dose is something we didn't have the luxury to do during the rush to get a COVID vaccine, but it is something that we really need to consider as we're trying to optimize the supply of vaccine. The next thing is just something quick from one of the Chinese vaccine companies to show you that companies around the world struggled with optimization. This is the Sinovac vaccine. And in fact, if you gave the Sinovac vaccine at week 4 rather than at week 2, you increased the level of neutralizing or protective antibody. Again, optimizing the vaccine dose could have very dramatic implications for vaccination programs. So if you have to give the vaccine every, at time 0 in week 2 versus time 0 in week 4, it gives the vaccination program time to recover, time to plan, time to implement more effectively. So again, all of these considerations need to be looked at in 2021. Optimization needs to be studied. This isn't something that I or a vaccine expert in the UK or in Europe is going to pull out of their back pocket and say, it's okay. We can give a vaccine instead of the way it was tested at time 0 and time at 21 days. We can space it out. We can give it at 90 days rather than day 21. I think that we really have to understand that when we do things, when we change regimens that have been tested for safety and efficacy, we really do need to be sure that they're going to work. And to do that, we have to study it. So the US government is considering half doses of Moderna vaccine, but as John Mascola at the Vaccine Research Center at the NIH and Dr. Fauci said, well, yes, we are studying it first. The UK announced a number of changes, and immediately there was pushback from medical groups that are saying that's not how the vaccines were developed. That's not what the studies say. You really have to be careful when you do this. And in fact, Steve Hahn, the head of the US FDA, issued a statement in the beginning of January this year. However, at this time, suggesting changes to FDA authorized dosing or schedules of these vaccines is premature and is not rooted solidly in available evidence. If we're going to convince people that vaccines are safe and efficacious, we have to lead with science. And the science at this point does not necessarily support changing the regimens at will. Correlates of protection, a laboratory test. Now, this is really important, and it sounds like one of these lab science things, and in fact it is. But what it tells us is we look at all the people who were vaccinated and got infected. We look at a similar control group of people who were vaccinated and uninfected, and we look and see whether the presence of neutralizing antibody correlates with protection. Once we know what that neutralizing antibody correlative protection is and what level is protective, then we don't have to necessarily do a trial in 40,000 people. We can do a trial in 400 people, which means that developing optimal regimens and schedules will be faster. When new vaccines are coming out, they don't necessarily have to be tested in 40,000 people if we have a correlative protection. And you can see in this graph from the Bill and Melinda Gates Foundation when we expect to have correlates of protection from the different trials. And hopefully we'll be on course for this. But again, correlates of protection are not necessarily difficult to do, but it is pretty time consuming because these assays have to be very, very carefully quality controlled. Effectiveness and herd immunity. Remember again, phase 3 trials are done the way they're done in order to very, very precisely determine without any bias whether a vaccine protects an individual. What we really need to know is whether a vaccine will protect the community. At what level do we have to achieve a vaccination in order to get herd protection? And you can see actually for the different types of diseases, measles, for instance, that in order to achieve herd immunity, we have to have, for instance, greater than 90% of children or people vaccinated. This is with a vaccine efficacy of 94%. So again, different vaccines have different levels. With COVID-19 vaccines, we were thinking 60%, then 70%, and now some people are saying in excess of 80% of people need to be vaccinated in order to achieve the relevant level of herd protection. But we really need real-world evidence that's coming from vaccination programs that are now rolling out all over the world. The mutant coronaviruses, and this is actually just a picture of the spike protein showing where the mutations are that people talk about and that you've probably read about in the different newspapers. And you can see now that the two different vaccines, the Moderna and the Pfizer vaccines, appear to be effective at neutralizing the mutant coronaviruses. That's the last slide. Thank you very much for your attention.
Thanks, Jerome. Great talk. We have about 3 minutes left for questions. If anybody has questions, please put them in the chat. I have a few to begin with. I'm wondering what your thoughts are on vaccinations in children and like how, let's say you do a clinical trial and you include children, how do you like weigh the pros and cons against vaccinating children?
Right. So children are a special population. And so when we are doing, so for instance, IVI has developed a typhoid conjugate vaccine. So typhoid is an infectious disease caused by a bacterium. The vaccines that we have now don't work in children. And so we are working with a number of different companies to develop a typhoid conjugate vaccine that was developed in our laboratories. We start by testing it in an adult population, healthy adults, 18 to 55, and then we back it down into adolescents, and then we back it down into toddlers, and then into infants. And so you have to have a gradual step down into the correct age group. This is going to happen. Some of the companies are already starting to do the age de-escalation studies in order to ensure that we can vaccinate children safely and to see very critically that children have the same protective immune response. So for instance, the standard typhoid conjugate vaccine that Sanofi makes is effective in adults, good for 5 years. It doesn't work in kids who are 2 years of age and younger. And so we have to really make sure that these develop the correct protective responses. And again, we're not going to do a 60,000 child study. We're going to base this, if their protective responses are similar to the responses seen in adults, particularly if we have a correlate of protection that we can use to base that judgment on, then we're going to assume that it will work in children also.
Nice. And where would pregnant women fit in a trial? Like when do you start including them?
So often in the phase 3 trials, we don't include them because of unknown risks to unborn children, and it is a very difficult thing. Eventually we will collect data, especially as these effectiveness trials are rolling out in women who were vaccinated and didn't know that they were pregnant. And so that follow-up of birth registries will indicate that the vaccine is probably safe in pregnancy. Less is known about RNA vaccines and viral vector vaccines in pregnant women. So that would be the adenovirus, chimpanzee adenovirus vaccine, for instance, from AstraZeneca. Likely there are going to be people who were vaccinated who became pregnant, and follow-up of those individuals will give, I think, regulatory scientists, the people who work for regulatory agencies like the FDA, more comfort with the idea that the vaccines don't harm pregnant women or their unborn children.
Great. Well, we're about out of time. So if there are any extra questions for Jerome, you can either put them in the chat or we have a Slack channel for further discussion for this section. So thank you again, Jerome. Very interesting talk.
Okay. Thanks.
Okay, our next speaker is Ariel Koren. Ariel's from the Respond Crisis Translation Organization. which is a network of translation volunteers providing compassionate, effective, and trauma-informed interpretation and guidance for COVID-related stuff. So Ariel, it's very nice to have you. Feel free to unmute, share your screen when you're ready.
Thank you. How's that?
Looks good.
Great. Well, thank you. And hi, everyone. My name is Ariel, and I'm the founder of Respond Crisis Translation. And I believe we were invited to be a part of this summit because we really want to be partnering with you, the leaders who are at the helm of the COVID-19 response efforts globally and across particularly Anglophone areas, the United States, to be ensuring and to work together to ensure that language accessibility, language access can be centered, can really be at the center of all COVID-19 response and aid work, because we need as a community, as a COVID-19 response community, to ensure that we're avoiding excluding hundreds of thousands of people from essential aid and resources. So I want to share a little bit about us, Respond Crisis Translation, and how we're partnering with the COVID-19 response community to ensure a language accessible approach. We, Respond Crisis Translation, are a global collective, a network of passionate multilingual people who are providing emergency crisis translation and interpretation services to asylum seekers, migrants, and really anyone who's experiencing crisis and needs these services. And since the start of COVID-19, we've partnered with over 50 different NGOs, clinics, hospitals, school districts, decarceration and housing justice, activists, and psychologists to do a really broad range of COVID-19 response, translation, interpretation, and language advocacy work. And I want to start, before we even talk about COVID-19, I want to start with just some really high level, brief context about why we even began to do the work that we do, why Respond Crisis Translation was started to begin with. So a little bit of context: the United States is home to 51 million migrants, 19% of the world's migrant population, and obviously a country that is at the receiving end of so much linguistic and cultural diversity, you know, we might expect would have inherently the capacity to receive such a breadth of linguistic diversity. And yet 85% of students in the United States lack access to foreign language education before high school. The United States federal government invests $0 on initiatives to support multilingualism among youth, which we obviously hope will change with the new administration. And the United States is widely considered the least linguistically competent nation in the world. So, you know, this kind of lack of language capacity and language incompetence all ladders up into what we know is a major translation crisis at the United States border, and also within United States borders in United States asylum systems and migration systems. The United States government does not provide any subsidized translation for asylum cases, in spite of the fact that asylum seekers are required to submit all documents in asylum applications in English in order to be considered. Judges are notorious in the United States for disqualifying asylum claims based on small language details and language technicalities. And people in asylum court, asylum seekers are regularly denied access to interpreters who are qualified, or interpreters who speak their language at the necessary level in order to do the job. So, you know, a lot of the time, I think it's natural for folks to say, oh, you know, this is new. This is something that happened as a result of the Trump administration. But today is International Holocaust Remembrance Day, and I think some context is relevant, and for us to remember that this is there's a long history of this issue existing. In 1939, the United States State Department was under the leadership of a vocally and notoriously anti-Semitic Breckinridge Long, and implemented a series of paperwork technicalities that were used as a tool to make getting asylum nearly impossible. So there was a visa application form that was implemented that was 8 feet long, so significantly longer than my body, printed in tiny type and available only in English, in spite of the fact that Holocaust refugees disproportionately did not speak English. And historian David Wyman described these technicalities, these paperwork technicalities, as paper walls that meant the difference between life and death. So we often speak about Trump's infamous physical wall, but obviously paper walls and word walls and language walls have existed for an extremely long time. And there's kind of, in addition to all of the translation and interpretation work that we do in Respond Crisis Translation, we also respond actively to what we believe is the myth that there's just some sort of coincidental or innate lack of language capacity that exists really in the United States, but in general amongst Anglophone people, that they're just not good at languages. We're just not good at languages. And in Respond Crisis Translation, we actively challenge and interrogate that myth, because the truth is that this isn't a coincidence. Americans are not just inherently bad at languages, but rather Americans are surrounded by a culture that privileges Anglophone people and Anglocentricity. And Anglocentricity is an oppressive linguistic structure that's wielded, unfortunately, often intentionally, to make mobility impossible for linguistically diverse populations, especially asylum seekers. So in all of the work that we do, we center this truth. And I want to share these cases. A couple of them came to us during COVID, some before COVID, but some testimonies and some stories from some of the clients we're working with that I think paint the degree to which language
Ariel, I think you might be temporarily frozen, but we'll give it a, oh, there you are, you're back. Do you want to repeat?
Where was I lost?
30 seconds or so?
Okay, so I'm going to share basically some testimonies from some of the clients that we work with that really, I think, paint the degree to which language violence is at play. EJ is a client of ours who is a speaker of an indigenous language who was only provided Spanish court interpreters, so only speakers of Spanish, in spite of the fact that this is not the language that she speaks, for 6 months while detained by ICE, and then was issued a deportation based on insufficient evidence. But this was based on, testimony that she provided to an interpreter who did not speak her language. So this is one of the clients we're working with. IK is a client of ours who's a Spanish speaker who had key details of her case mistranslated by an official court interpreter during a credible fear interview and was issued a deportation based on this. Another client, DR, fled her home country after experiencing extreme gender-based violence. She was not allowed access to a female interpreter and felt embarrassed sharing the details of her experience in front of only a man. So, these are 3 of really thousands and thousands of cases where language injustice, lack of language accessibility can have life-threatening results for hundreds of thousands of people. And these issues existed long before COVID-19, but COVID-19 has shined a glaring light on this language access crisis. These are, 3 news clippings of so many, and obviously even more stories that were never reported in the news. Hospitals that were unable lack of linguistically diverse people who were helping with mutual aid response, leading to complicated capacity for pandemic response all over the country. This is just one example from Nashville. School systems and districts are another example. Language barriers made it really difficult for parents who are non-English speakers to assist their children in becoming onboarded onto remote learning solutions. So school districts, education leaders, et cetera, who are struggling to facilitate these really important processes for families amidst school shutdowns, psychologists and domestic violence centers that were unable to support domestic violence survivors, as domestic violence was on the rise during COVID because of shelter in place orders. You know, the list really goes on, but all of the areas where we see language inaccessibility were just, you know, had that really glaring light shining on them when this pandemic hit. Now, these are some data from a report that we did in August 2020, but they're still relevant because this is still happening. We know that incarcerated and detained people were the most vulnerable populations amidst 2019, obviously because of the lack of ability to isolate. ICE in August of 2020 reported over 4,000 detainees testing positive, which we actually know is an underreport, but there were at least that number of detainees as of August, so really a while ago now, who had you know, tested positive for COVID. And even after detainees began to test positive for COVID, 66,000 people were newly detained, and this is just as of August. So ICE continued to detain people even in spite of the fact that COVID was spreading across detention centers. And ICE continued to deport people, and obviously deportation is a super spreader, right? ICE made 232 deportation flights in just the first 2 months of the pandemic to the Caribbean, Mexico, and Central America. And when we look at the detainee population, an estimated 25% speak indigenous languages. Most have no access to interpreters. Even before COVID-19, really that became zero access to interpretation. And of course, being released becomes impossible if an asylum seeker is unable to communicate with a judge during a credible fear interview. And so as of August, our team was receiving letters from folks who were detained asking to translate wills and to write wills because they thought that there was just absolutely no hope. So, you know, what are we doing as a language access and language justice collective amidst COVID-19? So as I mentioned, we're partnering really with folks who are working to respond to COVID-19 from all different angles and sectors and intersections of society, NGOs, clinics, hospitals, organizers, mutual aid efforts, etc. Where we work on, you know, the translation of documents in a crisis and kind of emergency manner for migration and asylum processes, obviously prioritizing people experiencing detention. We work with pro bono attorneys and their clients, but we also provide interpreting in clinics and hospitals, video interpreting for folks who need support, you know, seeing a doctor who is understaffed when it comes to interpretation. Psychological services and domestic violence hotlines. We work with schools, public education systems, education leaders who are working to create an accessible kind of flow of information around schooling and education details for their students. We facilitate calls between teachers and parents. We translate key safety protocols from different NGOs and organizations into both written and oral languages. We work with housing justice folks, rent strikers, folks working with people experiencing housing vulnerability as a result of COVID-19. And we work with media and news hubs to translate news into languages that are often underrepresented in media and news to make sure that news about COVID can be accessible as well. And here are, you know, a few numbers about the work that we've done. We're a very new organization, so we had just kind of formalized our identity as a nonprofit a few months before this public health crisis began. And we were kind of just in the right place at the right time and really like in the trenches when this public health crisis hit, and we're able to respond and to do this work across over 87 different languages with a group of translators that is now actually over 2,000 qualified and trained interpreters and translators. So we're here and we're a part of the summit, and we hope that you, the leaders of COVID-19 response work and efforts and aid, will make language access a priority in all of your response efforts. And we want to really just make it clear that we're here and we want to partner with you if you need that kind of support, and if that's something that is interesting for you as an individual or for your organization. This means, obviously, what does it mean to center language access? It means that all essential resources before being distributed should be translated into languages that are relevant for the community that the resources are being distributed in. It means that interpreters are present at clinics and hospitals. It means that vaccine information is available in different languages, that vaccination sites have interpreters, that conferences and news briefings and information hubs should be translated. Even a conference like this should be translated. Websites and written information should be translated. So we are here to partner with you. If you need that support, you can reach out to us directly on our website, respondcrisistranslation.org, or by sending an email my way directly. We would love to partner with all of you and any of you to make sure that language access is being centered. And also, if anyone on this call is interested in being involved and helping us and supporting us as we continue to mobilize, we are doing kind of a lot of work to right now fund language access. Folks who are Indigenous language translators and translators for languages whose communities are disproportionately COVID salary income impacted. We're doing work to make sure that these folks can actually have income opportunities, that they can be paid for their translation work, and that we can continue to serve people who experience financial vulnerability, don't have access to fund, legal, and language support. So we want to be able to continue to do this work. So if you're interested in contributing, that is obviously so appreciated. And of course, if anyone is interested in getting involved and being a part of our team, we welcome people from all different kind of sectors and expertise areas. Translators, interpreters, and multilingual people with relevant experiences are always so needed. And of course, folks who are interested in supporting in other ways are also always needed and welcome on our team. So thank you so much, and we hope to be in touch and to be able to work with you.
Thanks, Ariel. Great presentation, and thank you for all the hard work that you and your group is doing. We have some time for questions. There's one in the chat that's just asking what sort of qualifications that you guys are requiring for volunteers.
Yes, absolutely. So qualifications we require from our volunteers. First of all of our volunteers go through a screening process where they're screened by professional interpreters and translators. And we also kind of have subgroups of different interpreters and translators who have subspecialties. So if you're a medical interpreter or translator, you'll be working more on medical work. If you're a legal interpreter or translator, you'll be doing that sort of work. Folks who have experience working with, for example, LGBTQ people or trans people or folks who have experienced domestic violence will also be doing that sort of work. So we make sure that you're really kind of aligned with where your expertise lies.
Great. I have a quick question. I wonder, like, where is the bulk of your translation work right now? Is it like COVID stuff or school stuff or?
Yeah, I would say before the pandemic, we were disproportionately focused on supporting detained asylum seekers, obviously just because the need was so immense, so specifically in detention centers. And then when COVID hit, courts shut down and we mobilized to support really any organization that was doing COVID related work. So that was kind of the beginning of when we started to work with school districts, clinics, hospitals. We've been doing quite a bit of work with folks doing like medical research who are launching surveys, for example, in linguistically diverse populations to understand how different populations are being affected by COVID, and also to spread information. So in terms of where the bulk of the work is, I think now it's pretty even. And the idea is really just to support wherever we're needed and to make sure that translators and interpreters who are specifically qualified to do specific types of work are able to be matched up with that work.
Great. We have one more question about if you guys are automating translations at all, or if you're doing everything manual. And if you are automating, maybe you could tell us about how.
So no, actually, all translators and project managers are responsible for the quality and the outcome of their translations. I actually myself used to work at Google Translate and am still very connected to the Google Translate community. So obviously the power of technology to facilitate translation work is absolutely wonderful, but the type of work we do is extremely high stakes, extremely complicated, many times oral and client facing, and needs to be trauma informed. So, for a machine to do trauma informed work is very close to impossible. However, there are some translators in our work who might use a machine to translate and then will kind of proofread, which is becoming really kind of, a standard now in the translation world and industry. But if there are folks here who are interested in contributing from a technological standpoint to our work, please do get in touch.
Great. And I see our friends at Make Good Together have posted some links in the chat for people to sort of follow your work and volunteer if they'd like. So thank you again, Ariel. It was very nice to have you here.
Thank you. Okay.
Our next three talks are actually like somewhat related. So what we did is we sort of grouped them together. They'll each be, I think, 15 minutes. And then we're skipping Q&A between the talks and just putting like a big chunk of Q&A at the end of the talks. So our next speaker is Kim Prather. Kim is a distinguished professor and chair in atmospheric chemistry at UC San Diego. She's recently become a member in the National Academy of Sciences for her contributions in aerosol chemistry. And she's been sort of warning the world about airborne transmission for several months now, and we're all very thankful for that. So Kim, thank you for coming. The floor is yours.
Okay, thank you. And thank you for having me. I really appreciate the invitation. It's been really interesting to listen to all the different things going on and not feel so lonely. I definitely don't feel so lonely on this communicating science. I found a lot of the talks about communicating science really interesting. A lot of overlap is what I will say, as you will hear when I step through. So let me see. Okay. So, as was mentioned, I'm going to be talking about the airborne transmission of SARS-CoV-2 and how I a little bit about how I got brought into this. My background, I've studied aerosols for now nearly 30 years. And I also direct a large National Science Foundation Center at UC San Diego that's listed here that we affectionately refer to as CATE. And so, I study viruses, but viruses that are in the ocean. We just started looking at viruses that become airborne from raw sewage. And so, this has been sort of an interesting path to get drawn into the science communication aspects. So I'm just going to start out with the punchline and the main message that I have been spending, I guess nearly 10 months with a variety of other people, which I'm doing a shout out to here because I think a few of them are on this call as well. The COVIDISArborne team. It's been an amazing team. Somebody earlier talked about independent advocates, and that's what we are. And it's a group that is sort of assembled in a very ad hoc way, largely on Twitter. But we've worked together to try and get out a message. There's people with medical backgrounds, people with infectious disease, epidemiologists, aerosol scientists, just people that are genuinely interested in helping. And so the two messages are, we've got to get a unified message that COVID is airborne. It's every bit as airborne as else we've ever called airborne, including SARS-1. And once we acknowledge it's airborne, people have said, don't use that word because it creates fear and people start thinking of all, floating through the air, the mist. But the truth is it is airborne. And if we acknowledge it, you shouldn't be afraid because it's a very fixable problem. So it's a positive message. It should be viewed as a positive message. So one of the things that I sort of I just kind of start out with the punchline of where we are. This talk had me think about where are we? And I was thinking about this talk, and I went and I just did a quick tweet, and I was never a tweeter before. And this is the tweet that I put up. And what was interesting to me was what happened to this tweet. It's a tweet on viruses, and it went viral. It hit over 1 million impressions very, very quickly. This wouldn't have happened. So this was a kind of a positive sign that the messaging is getting closer. It's not where we wanted, you'll hear today, but it's getting there. And that this never would have happened even 3 months ago. And so, basically the point is that we have to acknowledge, this virus, the way it's formed is in speech. Aerosols produced in speech, the tiny stuff that floats in the air, more like cigarette smoke, not so much the droplets like you see in this picture here, which is what we've always thought about before. That has been the focus largely of the medical community in the past. And so, what was interesting was also the response that I got. How is this even a question? I thought we knew this. Why are we talking about this again? Done deal. Why are we still tweeting this? But as I will talk about today, we still have to keep saying this. I feel like a broken record sometimes because I say it almost every day. Sometimes I say it multiple times a day. So just to review sort of what are the options in terms of transmitting respiratory pathogens, just assume that not everybody has this background. This is where I started. This is a figure that Lindsay Marr has become a close collaborator and friend of mine through this process. I've made lots of friends all over the world. And, this is the way that you can get infected. But largely we've thought about, at the beginning, you remember this pandemic was like wash all surfaces, clean surfaces. And that's through contact where these big droplets, can get on surfaces or get on you versus aerosols that we don't think as much about. And there's this break that you hear about that's in medical textbooks. That 5 microns, anything above that will fall to the ground within 6 feet. Anything below that could go a little bit further, but this is where kind of the 6-foot link came up. And so what I want to talk about today is why that break is so problematic in messaging. So speaking of messaging, early in the pandemic, many people, including WHO director at the time, said, SARS-CoV-2 is airborne in February. This was just stated as such. In March, it went backwards. All of a sudden, people started not saying it's not, they weren't even just not saying the word, they were saying it is not airborne. This is a tweet that you can still find from the WHO on this topic. And there was just general confusion in the public. And if you think about it, the public's not going to do the right thing if they don't understand and they're confused and they lose trust. We have to basically be able to be clear with the public. If they get it, the chances of them, doing the right thing, it goes up. And so, why can't we use the word airborne? And so I, again, came at this as an atmospheric chemist and looked at all of what was going on, the tons of papers that were coming out very quickly, and kind of connected the dots and sort of wrote this perspective that appeared in Science that's now been downloaded, over, I don't know, it's getting close to 2 million times. But it was just sort of saying this virus is largely being spread by people who don't know they're sick. We don't have enough testing, so we need to wear masks. And so it really highlighted why why you should wear masks, both to block what you're putting out potentially if you are sick and you don't know it, and also what you're inhaling. I wrote this with colleagues. One is Chia Wang. People were talking about Taiwan a couple of talks ago. She's from Taiwan, and I have collaborations with them with an aerosol center. The other is Chip Schooley, who is the editor-in-chief of the Infectious Disease Journal. And I wanted to write it with a medical doctor, just because I didn't want it to be like an aerosol scientist just coming in and sort of lecturing the medical community. And it was a broader, view of where we have to go. The interesting thing at the time was it was very obvious that Taiwan stood out. And Taiwan stood out because they learned from SARS-1. And so, basically, to date, they still only have had 7 deaths. And I think a large number of those, if not all of those, were, quote, imported. So it never took off in Taiwan. And it was largely because they took masks and social distancing and the recommendations very, very seriously. But the focus here was really on the importance of aerosols. And so scientists as a whole, a group after me, Lindsay Marr, Don Milton, Lydia Maraska, people all over the world, we put pressure on CDC and WHO by writing and signing this letter that became infamous, 239 scientists. Lindsay wrote an article in in the New York Times. There's just a huge, this is just a few examples of all of this sort of, just massive effort to try and get the word out that this virus is definitely in the air and is being inhaled. And that's a large part of how it is being transmitted. So what was CDC doing during this time? Well, that's an interesting thing here in the United States. Basically, CDC, there's a very special meaning to the word airborne. It means long range, and Jose will talk more about this in his talk, so I don't want to talk too much about it. I just want to make the point that the messaging has been changing constantly for a variety of reasons. We've had a little kind of a wild time here in the United States politically. But there was this one day, September 18th, it was just such a happy day. I had spoke with Fauci and convinced him that, 5 microns is not correct. And so he kind of lit up and started talking about aerosols in August. Then in September, this happened. CDC quietly put up guidance that said airborne is the main route that it's being transmitted. It was on a Friday. As quietly as it went up on a Friday, it came down on a Monday. And so we're back to kind of confusion over what is airborne, what is aerosol, long range, how are people exposed. Bottom line, the messaging still is not quite there, although I have hope that it will get there soon, because there's been some changes that should allow that to happen. So since this messaging was getting a little crazy, one of the people I met was John LaPook, who's CBS chief medical correspondent, which is one of our big news channels. And I don't know how many shows I did. I mean, I've done hundreds of interviews, and he was the one that I worked with the most. And so he said, well, it's all confused again. Let's go pull together, you and Lindsay, and let's just, try and guide the conversation again. So we did this talk, we created a website, we did all this stuff to try and get it out there again. No, this is really airborne and we need to be able to do something about it. I also came back to science and said, okay, we'd had this National Academies workshop, which was on the airborne spread, which brought all these experts together from all over the world. All the experts don't question that it's in the air and it's in aerosols. We all came together, but one of the points of the discussion that we had during this workshop was that this 5 micron cut has got to go. And why don't we make a cut that has some physical, reality? And so we picked 100 microns as the cut. And we did that for 2 reasons. One is that 100 microns actually magically turns out to be kind of the distance that basically things will fall. These big, huge droplets will fall within 6 feet. Whereas things less than 100 microns will tend to float, and they can accumulate in poorly ventilated indoor spaces, which is a big part of how this virus is making its way around. So not only does 100 microns separate how it behaves in the air, it also basically will separates how it's transmitted, because it separates it into those that you inhale, less than 100 microns. The smaller they are, the deeper they go in your lungs, versus the bigger stuff that can just sort of splat on you as sort of a ballistic cannonball. And so this was something we proposed at the time that was well received. Interestingly, within 7 minutes of our paper the embargo being lifted on our science letter, CDC came out. They updated their guidance again, and now they're getting closer. We're back to airborne being important, but there's still different parts of the website are still being worked. And now, because of the change in our leadership in the US, they're going back and they're going to look at all the recommendations and completely sort of revamp things to get them more consistent, which is really good news. So, we've done, there's a bunch of us. It's been a really amazing group to work with. It's been exhausting, as any of you have. We've had all the same trials and tribulations as like the Ireland team. It just sounded so familiar. We've tried to spread the word as best we can through workshops and the media. How can you protect yourself? The public has come to us in droves. Please help, because we're so confused. And when you help them and you tell them it's in the air, they're appreciative. Nobody has been really afraid of this messaging. And so, once you understand why it's there, you can make the choices that you can protect yourself. And so I think the public has been really, really wanting this level of information. So where do we stand? Well, basically, WHO this is their most recent tweets. And so one of the big things that WHO has recently added is, open the windows, which hints at ventilation, which only affects aerosols, does not affect droplets, but they still are not airborne or even in the air. The word air, I don't think is there. Why do you open the windows? Again, for the public to it has to make logical sense. It just helps people a lot more. CDC, as I mentioned, is a work in progress, and they're gradually, I do expect big changes, and I'm hoping CDC will just be able to make the appropriate changes, and then WHO, they'll be more in harmony now that we're rejoining WHO. So why is it important? Somebody earlier mentioned, the why and the how. As I mentioned, the why is just so important so people understand why they're making the changes, and it also leads you to how you can fix it, right? And so I've shown some examples, they've done this. We're redoing things they did in 1918, right? Classes outside, ventilation. Really a big thing is our poor healthcare workers and frontline workers around the globe. Many of them are not being offered. In fact, some of them are being blocked the proper masks and protection, and are dying and getting sick in a disproportionate amount, which is just terrible. And so, the other thing is just contact tracing. Once it's in the air, this, 6 foot, 15-minute rule. What does that mean? When you're indoors, it's like cigarette smoke. It builds up. Everybody shares the air. So we have to be thinking about better ways to address it, obviously. So we also think about don'ts. When you're talking, don't take off your mask indoors. And, if you are, keep your distance. Face shields alone do not work. Plexiglass barriers can actually accentuate the aerosols that are where someone is breathing. Don't sing, or Jose will talk about this more in a little bit. Don't play musical instruments. There's all kinds of things you just start to realize, oh, I can't do that if I understand how I'm producing these. Especially, again, you're producing them, you honestly don't know you're sick. So the last thing, and I don't know how I'm going to do this real quick, Derrick. I hope I'm just to quickly touch on our return to learn. Should I do this or should I just end?
Yeah, go ahead. Take your time.
Okay. So I just want to touch on, because somebody talked about Cornell yesterday, and I really found it interesting. And UC San Diego, which is where I am, has a program called the Return to Learn program. And I'm very proud of this, to be part of this, because it has been a multi-tiered approach. And I just wanted people to know it's there. I can't go into all the details of what we've done. Lots of testing, fast results. The students have been phenomenal. We have these ambassadors who go around and make sure people are wearing their masks. And we have created what we call a safe bubble, which I kind of think of this as like a little model of what you could do. Think about a town. It is a town. There's 25,000 people there. So, how you could sort of think about things. We have this dashboard that's very transparent when we have infections, when we don't. We also do sewage. Water has been a huge way that we can find when people are sick, then get them tested quickly. Everybody in those buildings, it's linked to a building, so they have to go get tested. Anyone can get tested at any time for free. So we've made that very easy. Percent positivity, if you look at the community that surrounds the campus, it almost got to 15%. But if you look over that same period, when you just look over since the students came back, we've kept that positivity rate for the campus, students living on campus, most of the time less than 1%. It got a little higher in the middle of January, it almost got to 2%. The point being that when people follow and adhere to rules, even when they're surrounded by a community that has the cases rising pretty fast, we're able to keep things very, very safe. So again, I'm happy to share our plan, and if anybody's interested, but I'm a believer that the universities can be safe, even in an area where things are exploding, and they have been exploding here in San Diego in the last couple of months. So finally, I just want to leave with the message, and I hope that, I love having this global audience, but, we just need to send a clear, unified message. It is not that hard. I've heard people say it's not rocket science. Absolutely not rocket science. This is a friend of mine who's part of the COVIDISArborne team. Her 8-year-old daughter listened to me on one of my rants on CBS. And this is what she came away with. We just have to wear masks, and that's it. Spitball spaceships. We don't want those. And she even wrote recently a poem that goes with it. And, the messaging is not that hard. And, I guess it makes you feel good as a science communicator when an 8-year-old gets it. But we need to be our public health. We need to get those messages out about this level that people can understand. And I believe if people understood, they would do the right thing. And I'm going to stop there. Thank you.
Thanks, Kim. It was a great talk, as expected. It's nice to see that little poem at the end. Very nice. So we'll save questions for you until the sort of Q&A session after the next two talks. But thank you again for coming. So I'll just
Thank you.
go ahead and move on to the next speaker. Next we have Jose Luis Jimenez. Jose is a professor of chemistry at University of Colorado. Like Kim, he's been sounding the alarm on aerosol transmission for many months now. Today, we'll talk a little bit about the evidence that points towards aerosol transmission and maybe give us some tips about how to keep ourselves safer.
Okay, thank you for the introduction and for inviting me. I agree with Kim. This has been a really interesting workshop. I've learned a lot of things. So I'm gonna talk about a couple of things also related to aerosol transmission, but that Kim didn't cover in so much detail, which is how do we know it's airborne, very briefly, and how we can protect ourselves, in particular using CO2 meters. And there is a bunch of resources. The slides are online. There is the FAQs, and I put them both in the chat of Zoom and also in the Slack group in case anyone wants to follow up with any of that. Let's see here. Okay. So just to remind people of these droplets versus aerosols, because this is gonna, as I review the evidence, this is gonna matter. So we can get this virus if we touch a surface and then we touch the inside of our eyes, our nose, or our mouth. That's the surface path that we know is not important. The CDC says that is possible, but not important. And really is one of the two pathways that go through the air, these little balls of saliva, respiratory fluid that go through the air. And the difference is that the droplets are cannonballs, little cannonballs that come out of us when we talk or when we cough, and they have to impact the inside of their eyes, the inside of the nostrils, this little exposed piece, or the inside of the mouth. That's how they infect. And this is what WHO still says, and CDC, that this is the major pathway. And then there are the aerosols, which are the same balls of saliva, respiratory fluid, but they float like smoke, right, depending on the size. And then those inhale. And inhalation is, according to CDC, the main way we get infected, as Kim said. But anyway, things are still kind of confused in that message. So I'm going to review a few pieces of evidence about why we think we know it's airborne and why WHO says otherwise. So we know something that's very clear from all the contact tracing is that it's a disease that's easily transmitted in close proximity, like many respiratory diseases, right? And there is a video in WHO's webpage that was posted also on the 28th of March explaining how this is. And we have in the video, these droplets come out of this person who's infected and they impact on this other person, which is not keeping their distance. And that's how infection happens. This, again, the little cannonballs. And later in the video, they keep their distance and the droplets follow a parabolic trajectory. And then they may be a surface danger, but this person is safe because they kept their distance. The droplets have fallen to the ground in this case, a meter. And, you know, that's kind of how social distance is often justified. So this is a plausible hypothesis about why close proximity leads to infection and distance works. But the WHO has been making a logical error, and we told them in April. They assume this is proof that close proximity is proof of this mechanism, when it's only, this mechanism is only one possibility. There is really another possibility, which is with the one we think is correct, which is that as you keep your distance, or as you don't, you are inhaling more or less exhaled air from the other person. So this is imaging of CO2, and this is from a simulation, which is probably you can see better. And you see this person is talking, and the air comes out quickly, but then it slows down and dilutes and eventually rises because it's warmer. So if this person is here, is not inhaling much of the exhaled air and the viruses. If this person was there and was talking, you know, at closer conversational distance, they would be inhaling a lot more of this exhaled air. So both aerosols and the projectiles, both the smoke and the projectiles, the aerosols and the droplets can explain this pattern. You know, but the question is, if the droplets, if these projectiles are it, then as long as you keep your distance, you no longer need a mask. Do we see that, right? And the question is there infection when we share room air? And the risk is not as common as in close proximity, but because in close proximity, like if you imagine smoke, which is another aerosol, if you're talking close to this person, you are going to inhale a ton of smoke. If you're in a smoky room, you know, it's going to take a while. There's a lot of dilution. The volume in the room is much larger than the volume in front of the smoker, and the dilution may be a factor of 50. But this person can eventually inhale the smoke or the virus and get infected, right? And that's more, as you know, we see a lot of that, and I'll talk about one super spreading event. Something else that that is very well documented and is in the public health messaging, but not explained why, is that it's much easier to get infected indoors than outdoors by a lot, right? And this is a study from Japan when they did contact tracing, and they followed basically 110 people who were infected, and they had met with others before they knew they were infected, and then they saw, okay, the people they met with, had they gotten infected or not. 22 people had met with someone indoors, 88 people had met with someone outdoors. And of the 22 indoors, 6 didn't infect anyone and 16 did infect someone. Of the outdoors, of 88 people who were infected, 77 didn't infect anyone, right? And then indoors is the opposite. So as I said, 16 infected someone, outdoors is only 11. But also if you look at the numbers, outdoors is mostly 1, 1, 1, is someone they were talking to in close proximity, while outdoors you start to see 3, 3, 3, 4, 9, 12. You see super spreading, which is contributing to 80% of the transmission or something like that. And that only happens indoors, right? And then the question is, you know, indoors versus outdoors, if you are spitting projectiles onto someone else and you're talking indoor or outdoors, it doesn't matter. Unless it's really windy, those projectiles are gonna reach the objective. On the other hand, if you are exhaling smoke, that smoke is gonna be much more diluted. The wind outdoors is always 10 times more than indoors because it doesn't have the box of indoors that's limiting the movement of the air, and it doesn't have the ceiling to capture it. So really this can only be explained by aerosols, right? And by aerosols dominating. If it was 50-50 droplets and aerosols, then transmission will go down a factor of 2, but it goes down a factor of 20, right? What else do we know? And this will be the last piece of evidence I mentioned, is super spreading events, right? As the Michael Baker from New Zealand told us, you know, they did all this genomic testing in New Zealand, and they found that 80% of the people didn't transmit to more than one person, but there were some people that, you know, 20% of the people transmitted more cases, and that's what's found over and over. And I will briefly describe this case of super spreading that we investigated, the Skagit Choir in Washington. When this happened, it appeared on the Los Angeles Times, and I immediately called the reporter who put me in touch with the choir, who bent over backwards to help us. This is not a picture of the choir. We don't have pictures of them. They actually only half the people showed up because they already knew COVID was around, so it will be half the density you have here. And it's a very clear case, in my opinion, the clearest of the pandemic, because the choir is not social. They live on a large area, they arrive in time, they sing, then they have a 10-minute break, and then they sing, and then they leave because it's late. And everyone agrees, them and the public health and everybody, that out of 60 attendees, 52 got infected in a 2.5-hour rehearsal, okay? Including people who were 13 meters behind the person who later was known to be infected, right? So, you know, this is suspicious. So when we think now about the surfaces, droplets, and aerosols, what can explain something like this? Well, the surfaces, CDC tells us this is inefficient, and they knew about COVID-19, and early on, everyone told us these surfaces. So they have bottles of sanitizer, and nobody touched anybody, and they had the doors propped open. And then the person who was infected didn't touch anything, wasn't feeling so well, and then went to a bathroom when 3 other people went. You know, so impossible to get 52 people infected through surfaces. Could it be these droplet projectiles? Well, there was no one in front of the index case when the singing happened, and the index case didn't talk to anyone. And other people talked to about 2 to 3 people in the 10-minute break, right? And otherwise they were singing in fixed locations. So there is no way to impact droplets in the eyes or the nostrils or the mouth of 52 people for about 15 minutes, which is what CDC tells us. We need 15 minutes of close proximity. You know, it's just absurd to say that this could be caused by those projectiles, right? Could it be the aerosols? It's easy to explain. They were, you know, in a small room where the ventilation was turned off. The room is well mixed by the air from singing and the heat from the bodies, and they were not wearing masks. And as Kim said, singing or talking loudly produces much more aerosols. Okay, and then this explains the super spreading events well. And even quantitatively, you can see that the amount of virus in the air that this person was putting out was about 10 times larger than some other super spreading events, which is consistent here. They were singing all the time. And for example, in the restaurant in China, they were talking intermittently, right? And at a lower volume. You know, and this is one example, and I could talk hours about other examples, but the point here is that every time there is one of these events, they all point to aerosols. They, you know, more or less strongly, it's very difficult, you know, as I said, I think we were lucky this time, but it's very difficult to rule out any other option, but they all point strongly in that direction towards aerosols. And there is not a single event, there is not a single super spreading event that has been seriously investigated that we know, oh, this was the surfaces or this was this ballistic droplet. Zero, you know. And as we know, super spreading is very important, right? You know, so as Kim mentioned, WHO has this funny position that they say ventilation is important, and this is after a long time, and as Kim summarized well, a lot of campaigning and a lot of articles from scientists and a lot of things that we've been doing, but they don't say why, you know. So there is ventilation is important, and, you know, but why they don't say that, you know. So where does this come from, you know? So I think Kim touched on some of the reasons why there is such a resistance to saying it's airborne, but there is a historical reason that I wanted to at least put in your minds if you are not aware of it. Because in this field of epidemiology and infectious diseases, there is a denial of airborne transmission since 1910. Yeah? And it comes from this fellow, Charles Chapin, who later was the president of the American Public Health Association, and who wrote a book in 1910 summarizing a lot of evidence that had accumulated since Pasteur. And he talked about contact infection, and you know that became basically the germs don't live outside the body in the trash; they live in other people, and we get germs from other people. And he realizes close proximity leads to infection, and you know he wrote this book. But in the book he reviews the channels of transmission, and you know he says I wanna tell people to avoid being close to each other, avoid contact infection, but I can't if everyone is thinking, as apparently was the case at the time, that they were getting infected through the air. And he says, we don't have evidence, but I'm just gonna say he transforms absence of evidence into evidence of absence, and he takes some evidence from droplets that existed. And he says basically that, you know, we're gonna discard airborne infection, and he denies that airborne infection can happen. And this becomes a dogma in this field that exists until today. And when we met in April 6th with the WHO committee that dominates this determination, they are all Chapinistas. They are absolutely closed, and they come from this, and they don't listen to the evidence. It's a really bad failure of this part of WHO, in my opinion. Okay, so I've said kind of some things about that. I just very briefly wanted to mention a few things about protecting ourselves. So we have these FAQs that Kim and I and Lindsay Marr and many others put together, and it has, you know, all these things that you probably have already heard. So I won't dwell on that. You can look at that. But I wanted to mention a couple of things that maybe are less well known and I think are very effective. So the first one is using CO2 as a tracer of exhaled air. So we get infected by inhaling the air exhaled by other people, and guess what other thing they exhale is CO2. And actually there are these meters like this one I have here that cost you know, between $100 and $200. So they're affordable, and in 1 minute they tell you how much CO2 is somewhere, you know. And if it's 400 ppm, that's what's outdoors, that's what causes climate change. If there is 800 ppm somewhere where you're sharing the air, 1% of the air you're breathing, you are rebreathing it from someone else who has already exhaled it. If there is 4,400 ppm, you are rebreathing 10% of the air. And this is a common level in the schools, in buses, or several thousand ppm. You know, and this here you have in this link some monitors that we have tested and that work well. So this is me, you know, I was testing here outside, you know, it's a measure 400 and something. And then I went with my wife and our kids, 30 minutes in a car, and the car is a very small room that's closed, and it got very quickly to 10% of the air we were rebreathing, right? And this is very dangerous. And I mean, it was just our bubble, but if you share a car with someone else or you take an Uber or something, this can be a very dangerous situation. And ventilation works, you know, we kept the windows closed, but we just put the ventilation system, which was going to take air from outside instead of recirculating, and very quickly it went down to a much lower level, right? So this is something that can be done, and can be done in all the spaces where we share air. So what we're proposing is that, not just for the pandemic, because there are other reasons of indoor air quality and cognitive decline and high CO2, that every space where we share air should have a visible CO2 meter, and the technology exists to do this, say here 200, probably 100 or less, the Chinese get serious about this. And actually in Taiwan, there is a law. This is in schools, they have to have a meter and it has to be less than 1,000 parts per million. That was before the pandemic. And this can be used for schools. So we've been working a lot with schools, and this is a school in Spain where 2 different days they open the windows differently. And they saw this day, here the kids arrive and you get to some level, and they didn't open the windows enough. The next day they opened the windows more, and they got, to about 700 parts per million, which is what we think is feasible, even with cold conditions. So it's a very practical thing, and a lot of teachers can do this. We organize a GoFundMe campaign, and we've been able to gift 50 meters to a bunch of different countries. You can also investigate things like an airplane trip, and we've been, if you look COVID CO2 tag in Twitter, there is a lot of this, so here, this person went into the plane and most of the trip was okay, except boarding. When he was in the tunnel, waiting to get into the plane, and then in the plane, the ventilation system wasn't going quite well, and you had some very high levels of rebreathing the air from others. One other thing I want to mention is mask fit. So we talk a lot about masks, but a mask is basically a filter, and if the air goes through the filter, many of the aerosols will stay there. But if the mask has a gap and the air doesn't go through the filter, like it has a gap around your nose or on the side, like it's typical of surgical mask, then it doesn't filter. And a filter that's 2% of the area of the mask lets 50% of the air go through without filtering. So this is, I think, a message that hasn't been given clearly enough. You really need, these are some tests from a colleague, and with a surgical mask that wasn't well adjusted, the leaks were huge. Even with these KN95s or N95s, if you don't adjust them well, if you don't teach people to adjust them well, they actually leak a lot. And some of the good cloth masks, like this one that's larger, was not leaking at all in this test. So mask fit is something that's, I think, very important to mention. Okay, so I'm just gonna leave it there, and thank you for your time, and we can have any questions later.
Thank you, Jose. Let's see. So yeah, as Jose mentioned, questions later. We've got one more talk, and then we'll do like a little Q&A. Our next talk is from Deepti Gurdasani. Deepti is a clinical epidemiologist and statistical geneticist, and is currently a senior lecturer in machine learning at Queen Mary University of London. Today, she'll tell us a bit about COVID transmission in children. So, Deepti, welcome. It's nice to have you.
Thanks. I'm just trying to share my screen. Can you see my screen?
Yep, that looks good.
Okay, perfect. So I'm just going to do a brief talk on what we understand about childhood transmission of SARS-CoV-2 and bridging the evidence and policy gap in this area. So I'm actually a clinician by background. I trained in epidemiology and public health and did my PhD on the genetic epidemiology of diverse populations, particularly in Africa. And my current work focuses on using machine learning approaches to understand risk factors for global disease, particularly in the context of COVID right now. So before we sort of delve into childhood transmission, there are some important concepts here that often get mixed up. So there's the concept of susceptibility, which is how likely a person is to be infected with the same level of exposure as somebody else. And then there's exposure, which is how likely a person is to be exposed to the virus. So that depends on, the environments in which you come into contact with people in and the level of contact that you have with other people. And transmissibility, if you get infected, how likely are you to transmit it to somebody else in the same environment? The reason it's important to make these distinctions is because they've often been conflated in childhood transmission. And it's entirely possible, for example, to be less susceptible to getting infected, but still transmit more because you come into contact with many more people, for example. Or it is also possible, for example, to, maybe transmit less on an individual level, so have lower transmissibility, but really contribute substantially to transmission if you come into contact with large numbers of people. So when we talk about transmission, transmission in the real world actually reflects all of these: susceptibility, exposure, transmissibility, as well as the environment in which transmission happens. So studying childhood transmission has been really challenging, and anyone following this area will know that we see a lot of conflicting results from many different studies. And I think it's important to delve into why. One of the things we know about children is that they often have mild or asymptomatic infection, and this means that they are often not routinely tested as part of our regular surveillance systems or as part of our regular, test, trace, isolate systems. Children may be underrepresented. So this often means that infection may not be picked up in children, or it might be picked up, for example, in parents of children or in teachers or adults they come into contact with, who are more likely to become symptomatic when they develop infection. So this often means that children are not recognized as a primary case in a household, and the primary case or the index case may be wrongly attributed to somebody else in the household who was first noticed to have infection because they were symptomatic. There is evidence to suggest that false negatives on routine tests, so PCR tests, might be higher in children. And there's also some evidence now that seropositivity on antibody tests may be lower or may wane more quickly over time with children, potentially because they may have milder infection. So this means that many studies that rely on symptomatic transmission in children are biased. And unfortunately, most studies that have looked at this have focused on symptomatic transmission, and that's something to keep in mind. Another thing to remember is that overall transmission is context dependent. So, we said that a lot of this also depends on exposure, and children tend to have higher levels of contact than adults when they attend schools. So transmission in children may depend on many different factors. For example, whether schools were open or not, what the measures were in schools when they were open to reduce transmission, what was the background transmission in the region. If background transmission is low, super spreader events or outbreaks might be lower, and what was the level of attendance at schools. And the reason I mentioned this is because apart from a lot of studies being based on symptom-based testing, another limitation is many studies were carried out when schools were either closed or were close to most students and had very low levels of attendance, or when background transmission was very low in some countries. And all of these things make a difference. So how can we study this? There are many different studies that have examined childhood transmission. The most common type, I think, are household contact studies, which essentially look at susceptibility and transmissibility. These are also most likely to suffer from bias when they are based on symptom-based testing. There are seroprevalence studies that examine exposure and susceptibility. And then there are ecological studies, for example, that just look at the impact of school closures and opening on transmission over time and over different geographical locations. So we're essentially looking at what happens when schools close or open in different regions over time. And in some ways, this is less biased because it doesn't depend on, I guess, the symptom-based testing issues. But of course, there are other limitations of such studies, which I'll be coming to later. And another way to look at this is looking at infection among teachers and parents. So just to look a bit at household contact studies. So here's an example of, I'm not going to go through all the exhaustive literature on this because it's impossible to do in 15 minutes, but here's an example of a large study, for example, that was done in South Korea that looked at about 60,000 contacts of almost 6,000 index cases. One thing to remember here was this was another study that was based on symptom-based testing. So index cases were defined as the person who first tested positive based on symptoms in a family or in a household unit. And based on this, essentially, the study found that secondary attack rates were actually the highest across all age groups in 10 to 19-year-olds. So on average, secondary attack rates across all age groups were 11%, but in 10 to 19-year-olds, they were about 19%, but they were the lowest in children 0 to 9 years of age. So one thing to remember here is this study was done in households during school closures in South Korea. And to illustrate what a big difference that makes, if you look to the plot on the right here, which is a study from Wuhan and Shanghai during the period of the SARS-CoV-2 outbreak there. On the left, you can see the contact matrix of people who participated in the study during the period schools were open, and on the right you can see this when schools were closed, and you can see how high the contacts are among children when schools are open, and how they actually drop to much lower than among adults when schools are closed. So this context is really important in these studies. So sorry, I'm trying to so here is a study from England now that actually doesn't suffer from the same limitation as the previous study, as in it wasn't based on symptom-based testing, and it was undertaken at a point where schools were open, or at least schools were open during a large portion of when the study was done. So this was an infection survey. In England, we have an infection survey that's carried out essentially every week, and based on this we are able to identify people who are infected, including people who are asymptomatic. And based on this study, we actually find that although children, and there are two age groups that are presented here, there's 2 to 12-year-olds and 12 to 16-year-olds, we find that although they are less susceptible to be infected with a given level of exposure, we find that they are much more likely to be the index case in a household compared to adults. So for example, 2 to 12-year-olds are 2 times as likely, and 12 to 16-year-olds were 7 times more likely than adults to be the index case, or the first person to be identified with infection within the household. And once they were identified to have infection, they were 2 times more likely to transmit to other members of the household than other adults were. So that sort of throws out the myth that children transmit less than adults. And this is not just secondary school children, there's also primary school children. And while this may vary across different settings, certainly it's clear that children have the potential to transmit and contribute a lot to community transmission. And to look at this further with seroprevalence studies, which one may consider potentially less biased because we're looking at antibodies rather than infection based on symptoms. But what we find in seroprevalence studies is there's a huge amount of variability between different countries, and some of this might well be due to context. So for example, this study in Spain, which was a very large study looking at many different age groups, showed much lower seroprevalence, for example, in younger age groups compared to older ones. But this was carried out again during a period in March when schools were closed. And during that period, you would expect actually children to have less contact with others compared to adults who may still be working or traveling, etc. You can see that the picture looks different, for example, in Sweden and in some other regions. So in Sweden, for example, at this point in time, schools were open. So it's hard to sort of make sense of this. And what becomes really clear is a lot of childhood transmission is context dependent, and it needs to be looked at in that light. So moving on to looking at overall transmission. So we're not trying to tease out different aspects of transmission here. We're just looking at how school closures in different countries impact the R rate, or the reproduction number. And this is a study that was quite comprehensive. It looked at about 6,000 non-pharmaceutical interventions. They were hierarchical, so all of these could be broken down into much smaller, more detailed interventions. So in total, there were about 40,000 studied in about 79 territories. And this study actually showed that closure of educational institutions ranked as the second most effective intervention in reducing R. And here we can see it reduces R by about 0.2 because it's this one right on top. And they looked at this using different methods and they found it was consistent across all methods. They also tried to adjust for the fact that interventions can occur at similar times or at the same time using different methods. They even looked at interactions with other measures, and they found consistently that closure of educational settings was one of the most important determinants of transmission. And if we break this down further to look at the impact of primary, secondary, and preschool settings, which is something very few studies have actually done, we find that the impact of closure of preschool settings, primary school settings, and secondary school settings doesn't look very different. So looking at this, one may consider that different school settings in different age groups actually do all contribute to transmission and potentially even similarly to transmission. And this is another study that in a similar way looked across 131 countries at interventions that were carried out at different points in time and tried to look at the change in reproduction number, or actually the ratio of the reproduction number before the intervention was put in place and after it was put in place across all these countries. And this also found that one of the most effective interventions in bringing down R was school closure. And you can see that it reduces R by 20%, and conversely, opening schools or lifting these restrictions increased R by about 20%. And there are many other studies on, that look at this in a more sort of ecological way that have found very similar results. But looking now at infection among teachers and parents, which is another way that we can measure the risk of transmission from children. Here is a study from Sweden, which had this point in time where lower secondary schools were open and upper secondary schools were closed, which allowed a sort of comparison between teachers who were teaching the children in schools that were open versus teachers who were remotely teaching students. And here, for example, we see that parents had a 17% higher risk of getting infected when they were parents of children who were attending schools versus parents of children who weren't. Similarly, teachers had a risk of twofold higher when they were teaching children face-to-face versus remotely. And it's interesting that this risk doesn't just go onto teachers, but also extends onto their partners who were also at higher risk. So they had about a 30% higher risk than the partners of teachers who were remote schooling. And these measures were adjusted for things like household size, number of children in the house, and occupation. So this is by no means the entire breadth of evidence, but to just summarize this, children and schools do contribute substantially to transmission. And that's something we see consistently, at least across the ecological studies. And this is potentially to high contact rates because it does seem to be, to some extent, context dependent. And transmission is a composite of many factors. Like I said, we have to always keep this in mind when we read studies on transmission, particularly household studies, whether they were symptom-based, whether they were carried out at a time schools were open, what was school attendance at the time, and what were mitigatory measures in place, and also what was background transmission. There is still uncertainty around sort of individual susceptibility of different age groups and transmissibility of different age groups, but it's very clear that children can transmit even more than adults in some contexts at least. But unfortunately, this evidence is widely misunderstood due to flawed study designs, which unfortunately were never meant to be interpreted in this way and never meant to actually study this question. Given the large number of children who remain asymptomatic after infection, we definitely need study designs that are less biased to be able to examine this. So what is the impact of transmission in schools? Let's look at the direct impact. So one of the reasons a lot of policies to mitigate transmission have not been implemented in schools is this sort of thinking that schools are safe because children are not very affected by COVID, because very few children get hospitalized and very few children die of COVID. But children do suffer from direct impacts and long-term impacts. We know that long COVID, at least from the data within England, based on the Office for National Statistics, which actually carried out, again, a survey based on random swabbing of different age groups, found that 12 to 15% of children in school have ongoing persistent symptoms after the infection for 5 weeks or more. And there's very little we understand about long COVID, particularly in children, but we don't know if these symptoms sort of reflect long-term impact or multi-organ dysfunction. And these are things that we really need to study more before we consider exposing children to infection, in terms of large swathes of the population being exposed to infection in schools, which is what's been happening in many parts of the world. We also know that they can suffer from a multi-system inflammatory syndrome, again, poorly understood and rare. And of course, another impact that is not talked about very much is disruption to education. There's a lot of absenteeism that results from high rates of infection. For example, in England, during our last lockdown, about 1 in 5 children were not attending school because they were isolating or ill. And it looks like it has a very substantial impact on community transmission, which is very important and has been overlooked, I think, in a lot of policy. It clearly has an impact on teachers and staff as well, an impact on families, especially, if you have vulnerable members of the household. I can understand the anxiety people must feel having a child attending school, knowing that they might be at risk. And this translates ultimately to impact on mental health of, families, staff, as well as children. And if schools have to close because of high levels of transmission or have to move to remote learning, all of this has the potential to make inequalities worse. And the fact that many different parts of the world and even within regions, we have huge differences in what's available to schools in terms of mitigating transmission and the support available already has a potential to really worsen inequalities that already exist in this area. So what policies do we need? I guess the policies need to be based on background transmission. Of course, if you don't have much background transmission or you've eliminated COVID, you don't need to worry about this as much. But the policies would broadly kind of fall into mask use, social distancing, so that's physical distancing, looking at class sizes, having bubbles of children who don't mix with others, ventilation, testing if available, so asymptomatic testing if available, hygiene measures, which I think are being practiced in most areas, and protecting school staff. So, we need to really look at our vaccination policies more carefully, have PPE available for staff and shielding if necessary, and hybrid and remote teaching when community transmission is high and keeping schools open is not feasible anymore. And unfortunately, a lot of these decisions sometimes need to be made very quickly. So we need rapid response systems to be able to do this and have family and community support in place for the families who need it the most. And very importantly, we need to really address the structural elements that already lead to inequalities in education and provision across different families and prevent these getting worse because of the measures that we take. So how do we bridge this gap? I mean, this is an area that has faced a lot of resistance in terms of policy, despite the evidence for the role of schools in transmission being quite overwhelming. I think it's important we stop giving schools and children the special status or exceptional status that they don't transmit, or that they're not, or that schools are safe for them unless they're actually made safer. We need to acknowledge, first of all, transmission happens in schools and impacts communities, because if we keep denying that they are a source of transmission, we won't put mitigatory measures in place, which will directly lead to school closures when cases start rising. We also need to acknowledge uncertainty around impacts on children. We're hearing more about long COVID in children, and we're quantifying now the impacts in children. And just because we're not sure about what these impacts are doesn't mean that we shouldn't be cautious about them and try and prevent them. We need to tackle disinformation around this actively, which exists across policymakers in much of Europe at least, and perhaps in other parts of the world. And policy needs to be co-created with parents, with teachers, with head teachers, and with students to ensure that it's really applicable to the people who are going to be harmed if transmission continues in schools. And evidence needs to be applied consistently across settings. If we think people should wear masks in indoor crowded settings, it doesn't make sense then to say that children don't need to, or secondary school children don't need to. Yeah, so that's it from me, a kind of fairly short, brief overview.
Thank you, Deepti. So now perhaps we could move into our Q&A session. If you can unshare your screen, then I think we can have some of the other speakers pop up.
Sorry, I'll just do that. There we go.
Great. So there was a lot of talk in the chat, and especially like during this school thing. It's a pretty controversial subject. So yeah, I'm not exactly sure which thing to sort of start with, but maybe I could just ask the three of you whether or not you think, well, under what conditions should school be open? Just like a quick bullet point list, and then each one of you guys can answer. Maybe Deepti, you could start. And it's sort of like a personal opinion thing. So usually with like science advocacy or something, we'd say like, if this happens, this will be the consequence. But if the decision was up to you, what would you say, if you feel comfortable saying?
Yeah, sure. I mean, I think first, the trajectory of cases in the pandemic needs to be downward. So the R needs to be well below 1, and the number of cases in the community needs to be low. So I would probably aim for case numbers at least less than 5,000 per day. But having said that, it's also context dependent. So for example, if you have schools that are open with quite aggressive measures to contain transmission. So for example, if you have routine testing of children coming into school with rapid tests, then that could mitigate the problems with opening schools even at higher infection rates. So part of it is dependent on the policies that you have in schools, because the better policies you have to mitigate transmission, the more likely you can open schools at higher levels of community transmission. But if you don't have any measures to contain transmission in schools, then you should wait until cases are very, very low before you open them, because opening them will lead to a surge in cases right away.
Kim.
Yeah, I mean, I'm advising our big San Diego school district, and I have been for some time. And I'm telling people to wait for the community transmission to get lower. And I think also vaccinations, I think for the teachers, but also, I think I agree with Deepti. I mean, I've learned from her, but I also think that putting in the right mitigation. So, our school has been really aggressive in putting in the right filtration systems, putting in, if they can't put the right filtration systems in, sometimes it's not possible to upgrade these schoolrooms because they're so old. You put a leaky filter in, which is not good. So they've got standalones. The kids are going to be required to wear masks at all times. If they need to eat, they have to eat outside. So, I think if you, really establish and acknowledge it's in the air, the problem, and I'll just stop after this, the problem with most schools that I've seen and listened to all the conversations from everyone, many, I don't know if I can say most, but maybe most schools are still focusing on cleaning surfaces as their way to say that it's safe. They're not focusing on cleaning the air because they don't have, the guidance is still, especially in the US, I don't know about other places, but the guidance is still not there, is the way I would say it, from CDC. It's getting better. They've now added ventilation, so it's getting there. But until we can have the right way to do it safely. So I'm just telling people, while you're waiting for the community spread to go down, get the school ready to go so it's safe for everybody.
Jose?
Well, I think I agree with everything Deepti and Kim said, that community transmission has to be low, and we have to acknowledge how the virus is transmitted, and we have to do things to making it safe. I mean, I've been working a lot with Spain and Latin American countries, and there a political decision was made that the schools were safe as they were, without taking any measures other than masks that are often poorly worn, or the same mask is worn for 3 months with gaps everywhere. So, and community transmission continues to be very bad, So, yeah, I mean, I agree with what has been said.
The other thing I'll just add really quick before is that this gets at the issue, and I didn't go into it in my talk, but I just want to throw it out there. And I think I've seen comments flying by in the chat about this. What's contact? It's within 6 feet. So they don't consider, like, if, let's say, kids are sick in a classroom, they're only going to test and be concerned about the ones that are within 6 feet, some places 3 feet. And so that's kind of crazy to me. To me, I'm really pushing for masks at all times indoors, and you're sharing the air with everyone in that room. You just think about a cigarette smoker. And so, this concept of, oh, you weren't exposed if you were further than 6 feet away indoors is just so incorrect, is what I will add.
I second that. That's definitely policy in England right now. You just isolate contacts that are literally sitting next to you or in front of you, not even behind you.
Oh yeah, you have to be facing. Some of them say you have to be facing each other for 15 minutes. Yep.
Yeah.
Thank you, guys. And I wonder if you guys could give some quick, like, cheap advice for how to make a classroom safer. Of course, like, the cheapest thing is like open windows, open the classroom door. What else can they do if they don't want to buy expensive humidifiers or something, or any purification stuff or new ventilation systems?
Cheapest thing is the Corsi, what they call the Corsi box. And if you haven't looked up the Corsi box, it's on the fact that Jose put in, and I can let him comment, but it's a little noisy, but it works. It'll filter the aerosols out, no problem. And so that's the cheapest. That's $40 or $50 to build one. And so I'll say that that's, when I have talked to Fauci, they're concerned with some schools just can't afford to do all the things that San Diego schools have done. That's fair. But you can filter your air for pretty inexpensive. It's not a Cadillac, but it works, is what I will say.
I will second that. And then I think ventilation opening the windows can work in many places, but now in the winter in the northern hemisphere or summer in Argentina or whatever, and the temperature difference makes people close the windows, and because they don't understand things well, how much do we have to ventilate? Yeah, they say ventilation, but what do they mean? I think these CO2 meters are really golden, but really for $100 or $200, and you need one per school. You don't need one in every class. $100 per school, everyone can afford. And you give it as a project to the students. Go measure in every class, 5 minutes in every class. Very quickly you learn which classrooms are poorly ventilated or how much you need to open the window. And everyone who does this realizes that you can keep thermal comfort. You don't need to be too cold. I mean, maybe you need to be with your coat because it is 17 degrees C instead of 21, but it is not 2 degrees C, even if it's really cold outside. So I think that's why I was pushing that idea. I think it's really powerful.
Deepti, do you have any really quick, like, cheap ways to make a classroom safer?
I mean, I'm not going to speak to the aerosol transmission because I think people here know much more about that than I do. I mean, I would say definitely small class sizes is worth considering, and using large empty spaces where they're available, having bubbles that don't mix with each other, having isolation policies that reflect the aerosol transmission evidence, having mask use in secondary schools and encouraging it in primary schools as well, in line with CDC guidance. I think the CDC guidance on this is actually really, really good. It's just not being followed in most places, unfortunately. So I think if people just follow the guidance that's out there from the CDC, which seems fairly evidence-based to me at least, that would make a huge difference. And I think, if places can afford rapid tests, it's certainly worth using them, at least in secondary school children, in terms of routine testing. Even if they're less accurate, if they pick up new cases that can then be isolated, that would be a plus, because we would take those people out of the transmission chains.
Great. So we have to wrap up the session to let the next session begin. But thank you again to all the speakers. I saved the chat, and I'll copy and paste that into our Slack channel specifically for this session. So if anybody has any questions, wants to continue discussion, feel free to talk on Slack. So thank you, everybody, again.